her account and has been a part of many international Atomic Energy Commission national and international projects as well. Welcome to you, Dr. Shabana Saeed, as well. Now, our first speaker of this session is Dr. Jean-Luc Urbain. He's the president of World Federation of Nuclear Medicine and Biology. Dr. Urbain has been serving at various executive positions in the medical imaging and medicine in Belgium at University of Leuven, in Canada at University of Western Ontario, and in US at Temple University, Fox Chase Cancer Center, and currently at Wake Forest University Baptist Medical Center. He is going to give us a talk on cardiovascular nuclear theranostics. So I would like to invite Dr. Jean-Luc Urbain for the talk.
Hello, everyone. My name is Jean-Luc Urbain. I'm the current president of the World Federation of Nuclear Medicine and Biology and the chief and medical director of the Nuclear Medicine Program at Wake Forest University in North Carolina in the United States. I've been practicing nuclear medicine for more than 3 decades, and I believe that there has never been a better time to be part of the nuclear journey. Over the next 20-25 minutes, I'm pleased to share with you some current and exciting future application in cardiac theranostics. The word theranostics stems from the contraction of the words therapy and diagnostics. It was first coined in 1998 in the pharmaceutical industry to describe a combined diagnostic and therapeutic approach for patient management. One of the many outcomes of the Human Genome Project has been the identification of the oncogenotype and oncophenotype of tumors. Current nuclear theranostics takes advantage of the overexpression of receptors at the surface of cancer cells. Using radio-labeled specific ligands to these receptors, unable to identify specific targets, quantify the tumor burden, and when labeled with a killer isotope, to destroy the cancer cells. But the concept of theranostic also applies to different diseases and different approaches in patient management. For example, we can use the biomarker approach, the imaging guided, and the biomarker imaging approaches combined that determine the steps in patient management. And in fact, nuclear theranostics, as we understand it today, probably represent no more than 10% of the overall concept of theranostics. In the next few slides, I would like to illustrate the potential of the concept of theranostic in nuclear cardiovascular imaging. Let us first look at cardiac infiltrative diseases. Pyrophosphate is an ubiquitous metabolic byproduct of many intracellular processes found in most mammalian cells. And of course, it can also be produced chemically. Pyrophosphate acts as a potent inhibitor of calcification. It antagonizes the ability of inorganic phosphate to crystallize with calcium to form hydroxyapatite crystal. By occupying some of the inorganic phosphate sites on the surface of nascent growing hydroxyapatite crystal. Part of the healing process of some of the injuries to organs is the ability to form hydroxyapatite crystal and generate calcification. Technetium 99M pyrophosphate bind to calcium that is liberated by the injured cardiac cells in myocardial infarction, as it is illustrated here on this research study in Dock from 1975. And as you can see on this slide, control subjects with no infarction do not have any significant pyrophosphate uptake, creating an infarct to the inferior wall and to the anterior wall clearly show pyrophosphate labeled with technetium 99M uptake. In 1982 already, Weisenberg and colleagues first reported that technetium 99M pyrophosphate imaging may be positive in cardiac amyloidosis. And this figure is taken from their original paper. In their report, Weisenberg showed that in 10 patients with cardiac amyloidosis, there was significant pyrophosphate uptake at the level of the left ventricle. Clinicians have known about amyloidosis for several decades. In fact, amyloidosis was first described in 1639. Amyloidosis is a group of diseases in which abnormal proteins, known as amyloid fibrils, build up in tissue. The symptoms depend on the type of fibrils, and they are often variable. There are about 30 different types of amyloidosis, each due to a specific protein misfolding. Some are of genetic origin, while others are acquired diseases. Cardiac amyloidosis is a form of restrictive infiltrative cardiomyopathy that confers significant mortality. The diagnosis of cardiac amyloidosis is challenging due to the relative rarity of the disease, the clinical overlap with more common diseases that result in thickening of the myocardium, like hypertension, chronic renal failure, hypertrophic cardiomyopathy, aortic stenosis. But it's also difficult because of the unfamiliarity with the proper diagnostic algorithm and a perceived lack of definitive treatment. There are two major types of amyloidosis that affect the heart. Light chain amyloidosis refers to a situation in which plasma cells produce monoclonal light chain antibody that misfold. In transthyretin amyloidosis, a point mutation in the transthyretin gene leads to the misfolding and dissociation of a protein into monomers. In both situations, oligomers, protofilaments, and mature amyloid fibrils deposit in the myocardium. Once used to diagnose myocardial infarction, technetium 99M pyrophosphate imaging is now reborn as an alternative to biopsy for diagnosing cardiac transthyretin amyloidosis in patients. This slide shows two cases of cardiac amyloid disease which were referred to us by the Department of Cardiology for the assessment of cardiac failure in these patients. On the left side of the slide and at the top, you see that after administration of pyrophosphate, there is clearly uptake of the tracer at the level of what appears to be the heart. This is confirmed by the SPECT-CT images showing significant uptake at the level of the left ventricular wall. These patients adds a level 3 uptake at the level of the planar images, and the heart to control lateral ratio was about 2.5, confirming the diagnosis of cardiac transthyretin amyloid disease. On the right side of the slide and on the planar images, you can tell that there is a mild increased pyrophosphate uptake at the level of the heart. But the SPECT images demonstrate that, in fact, the uptake that we see is at the level of the left and right ventricular cavities. This patient had actually a case of light chain amyloid disease. And as you know, when you do a semi-quantitative evaluations of the heart to contralateral ratio, a ratio of more than 1.5 is highly suggestive of transthyretin cardiac amyloid disease, while patient with light change cardiac amyloid diseases ratio is most of the time, if not all the time, below 1.5. This is important, and the reason is shown on the next slide. The importance of the determination of pyrophosphate uptake in the heart is illustrated on this slide, showing that patients with a ratio of 1.6 or greater have a significantly poorer 5-year survival than those with smaller ratio. So it is important to give this type of information to your colleague in cardiology. The game changer in ATTR cardiac amyloid is that disease progression can be slowed down or prevented by novel TTR-targeted therapies. Inotersen and patisiran are TTR RSNA silencing agent that prevent the hepatic production of TTR protein. Inotersen is an antisense oligonucleotide, and patisiran is a SMILE interfering RNA molecule. Both agents have been studied in phase 3 clinical trial involving ambulatory patients with ATTR cardiac disease and polyneuropathy symptoms. Tafamidis is an oral TTR stabilizer that binds to TTR tetramers in circulation and prevent their breakdown into unstable amyloidogenic monomers. In the transthyretin cardiomyopathy clinical trials, over 30 months, tafamidis was associated with a 32% reduction in mortality and a 30% reduction in cardiovascular hospitalization. Another example of the usefulness of nuclear cardiology is in cardiac sarcoidosis disease. While it is believed to involve the heart in up to 20 to 30% of patients with systemic disease, in fact, the heart may be the only organ involved in sarcoidosis. Sarcoidosis can involve almost any cardiac structure, but the left ventricular myocardium, particularly septum, is the site which is most frequently involved. In advanced cases, the inflammatory process generates scar tissues, and aneurysm might result of the necrosis fibrotic process. Currently, the diagnosis of cardiac sarcoidosis relies on the comparison between myocardial perfusion and myocardial FDG images, where the FDG uptake reflects the inflammatory process at the level of the cardiac muscle. This slide illustrates the importance of having a sensitive and accurate test to diagnose the disease. As you can see on the left side of the slide, the baseline images demonstrate the heart, and there is also abdominal disease. After treatment, the uptake at the level of the heart is even higher than before the treatment, clearly showing that this patient did not respond to treatment at all. In contrast, this patient has extensive disease in the chest and the abdomen and at the level of the heart, as you can see on the baseline images. After treatment, there is a remarkable improvement with practically no significant FDG uptake at the level of the chest, the abdomen, and the heart, showing the successful response to therapy. In sarcoid disease, having a sensitive and specific tool to diagnose the disease and to follow up the disease and assess the efficacy of treatment is critical. The most exciting perspective in cardiac diagnostic lays in the availability of new radiopharmaceuticals that enable to evaluate the pathophysiology of cardiac ailments, essentially by labeling receptor at the level of cardiac and vascular cells. It is well known that chronic heart failure is associated with neurohormonal activation and alteration in autonomic control. In addition to the catecholamines actions and the development of interstitial myocardial fibrosis, the myocardial renin-angiotensin system has been closely related to the abnormal cellular and molecular alteration that parallel the left ventricle remodeling. Left ventricular remodeling, defined clinically as alteration in volume, shape, and/or function of the heart chambers in response to chronically elevated loading condition, has been appreciated as a central determinant of the clinical course and outcome of systolic heart failure. The identification and characterization of the renin-angiotensin system with molecular imaging in the individual heart failure patient is highly desirable in order to provide more precise information to predict and monitor the myocardial response to medical renin-angiotensin system blockade. It is also critical in order to fine-tune the treatment of these patients with heart failure. Although still in a research domain, the renin-angiotensin converting enzyme protein and the angiotensin type 2 subtype 1 receptor that are expressed at the surface of myocytes can now be imaged with PET and SPECT radiopharmaceutical. This slide shows the PET and SPECT radiopharmaceutical that have been used to label these proteins at the surface of myocytes. The imaging of the angiotensin type 2 receptor is shown on this slide in a normal pig model on the left side with a nice visualization of the left ventricle, and in a peak with myocardial infarction on the right, showing the CT delayed enhancement of the infarcted myocardium, the defect of perfusion in the anterior wall, and the visualization of the angiotensin type 2 receptor to the superior aspect of the anterior wall. As you know, the myocardium is a highly organized structure that contains several cell types, such as cardiomyocytes, fibroblasts, and endothelial cells, but also vascular and neuronal networks. Interspersed between these elements, the interstitium comprises a complex cellular matrix. Wound healing after myocardial infarction entails a cascade of events that involves a complex interplay between several different cell types, including inflammatory cells, endothelial cells, fibroblasts, and myofibroblasts. Myofibroblasts have characteristics of fibroblasts and smooth muscle cells. They produce extracellular matrix and are able to contract. In so doing, they can contribute to tissue replacement and interstitial fibrosis following cardiac injury. The balance between the synthesis and degradation of collagen during cardiac remodeling determine its turnover, and in the post-injury states, this process is regulated predominantly by myofibroblasts. Adequately healed infarct show preserved geometry, while inadequately healed infarct, in other words, with few myofibroblasts, show severe dilation and infarct expansion. Differentiated myofibroblasts express several targets that might be of interest for molecular imaging. The ATR, FRIS2, and TGF-beta receptor are reasonable candidates and easily accessible to targeting tracer molecules because of their extracellular localization. Additionally, the alpha V beta 3 integrins are expressed in the focal adhesion area and might constitute yet another candidate. The specificity and efficacy of these targets needs to be determined because, in fact, most of the targets are present on also other cell types. But nevertheless, they give the ability to researcher to image and quantify myofibroblast activity in infarcted areas. The imaging of the apoptotic pathway in myocytes in end-stage heart failure and in ischemic heart disease is a very desirable tool to have. Clinical imaging of myocardial infarction and myocardial apoptosis has clinically been evaluated by indium 111 label annexin 5, an endogenous protein that targets abundant surface exposure of phosphatidylserine residue. The yellow arrows on the images of the left side of this slide show the localizations of the myocardial infarction anteroseptal and anterior and the significant uptake of annexin 5. What about vascular theranostics? Well, annexin 5 can also be used to document the instability of some plaque where there is an activation of the apoptotic process. On these slides, on the top left, you can see a significant uptake of annexin 5 in this patient with a carotid stenosis with plaque instability. In contrast, in the lower left portion of the slides, there is no significant annexin 5 uptake in this patient who also had a carotid stenosis. Having the ability to image and document the instability of a carotid plaque is invaluable because it helps the neurologist and the neurosurgeon to decide on the emergency of performing a vascular procedure when the plaque is unstable in order to avoid a stroke in patient. There is no significant research in theranostic for the treatment and management of atherosclerotic plaques. As you know, atherosclerosis, which is a progressive condition characterized by the buildup of plaque due to the accumulation of low-density lipoprotein and fibrous substances in the damaged artery, is the major underlying pathology of most cardiovascular diseases. There are a number of potential cells and receptors involved in atherosclerosis, as pictured on this slide, that can be used for theranostic agent targeting, such as macrophages receptor, integrin AMB3 and VCAM1 receptors. Among these targets, macrophages are certainly the most commonly studied and used target because of its pathogenic role, phagocytic property, and abundance in the atherosclerotic lesions. Beside FDG, which is commonly used, there are now a few other tracers that are being developed to image the inflammatory process and instability of atherosclerotic plaques. Lastly, I would like to mention that the monocyte chemoattractant protein, chemokine receptor 2 axis, play an important role in abdominal aortic aneurysm pathogenesis, with effects on disease progression and anatomic stability. In this study, the authors assessed the expression of the chemokine receptor 2 receptor in a rodent model and human tissue using a targeted positron emission tomography radiotracer. They concluded that the imaging of the chemokine receptor type 2 can in fact predict the pending rupture of the abdominal aortic aneurysm. I would hope that through these slides, I was able to illustrate the current and enormous potential role that cardiovascular theranostic will play in the future of nuclear medicine. Thank you for your attention.
Thank you, Dr. Urban, for such a comprehensive and a visionary talk. Now, our second guest speaker is Dr. Zhang Zioli. He is director and professor in the Department of Nuclear Medicine, Beijing Anzhen Hospital, Capital Medical University. She is also a standing committee member of Chinese Society of Nuclear Medicine. She has an experience of nuclear cardiology for 30 years, and we are happy that she is today here with us to share her experience of prognostic value of myocardial viability and left ventricle remodeling in patients with ischemic cardiomyopathy. I may now invite Dr. Zhang Zioli to deliver her talk. Please.
Thank you for your introduction. The voice is okay?
Yes, it is okay. It is fine.
Okay. I would like thanks for the invite me have this presentation. It's my great honor to attend the ninth annual meeting and the third Sino-Pakistan meeting held by Pakistan Society of Nuclear Medicine. I would like to express my warm congratulations to all of you. I believe it's a good opportunity to exchange ideas and enhancement communication, friendship between Pakistan and China. Let me move to my talk. You know, heart failure is a global, an estimate 64.3 million heart failure worldwide, and in China is 4.5 million. So ischemic cardiomyopathy is the most common cause of heart failure, and if treated by medical therapy, very low survival. So it's a really challenge for all of us, and also many guidelines is very helpful to guide the patient treatment strategy. However, for the individual patient, it's really challenge. How to identify patient who could benefit from revascularization is very important. You know, nuclear cardiology have two major advantages to identification, myocardial ischemia, and hypertension myocardium has very important value to identify patients who could benefit from revascularization. Also, many multiple parameters could get the SPEC study and get the PET. We can get the regional and global function, and also we can have the phase analysis, and the left ventricle synchrony also can be analyzed. So many parameters by one procedure we can get. It is well known. Myocardial viability study was advocated firstly by Dr. Sherbert group and UCLA. And I'm very lucky when I'm a PhD student and Dr. Sherbert have a lecture in my hospital at the international meeting. So then I worked with him at UCLA in 2003 and 2007. Then also I started started the cardiac PET in China in 1997. That's the image at that time. That's the PET system, the 4 rings. The image quality not very well, but for the visual analysis is no problem. So after that, and our study is become the routine clinical practice, have many important value in the clinic. However, how to get a high quality cardiac PET image is still real challenge. It's a cost time, and also the patients with severe heart failure. We need to really be careful for the patient safety. At that time, we couldn't use gated study, so we use echo to measure the ejection fraction and also measure the left ventricular diastolic volume. We can see the ejection fraction gradually improved, and left ventricular remodeling was gradually reversed. So demonstrated the viable myocardium is correct. That's one case. It's not a very good, resolution is on the rail, but patients with a large amount of viable myocardium after surgery ejection fraction was much improved. We also know the hibernation myocardium is a progressive deterioration. and the cardiomyopathy was gradually lost and replaced by fibrosis. And for the nuclear cardiology technology, we can dynamic imaging to analyze the changes. So how long time the hibernation myocardium could be survived? You know, it's a difficult question because a lot of information was affected. And let's see one case, 74 years old, 3-vessel disease, large amount of, this is a RAS study, FDG PET study, large amount of viable myocardium in this case. But the patient rejected to be treated by surgery. So 1 year later, and the follow-up PET study, and we can see, we look at the image in septal wall. The perfusion, no difference. However, for the metabolism, is much significantly decreased. Large amount of viable myocardium in septal wall, but right now become the scar, and the EDV was enlarged. And 2 years later, the patient suffered from cardiac death. And in our study, the hibernation myocardium has important prognostic value. From the early study, that is 2001 published, and the patient with viable myocardium treated by medical therapy have a higher cardiac event and cardiac death. And the result was consistent with the meta-analysis reported by Allman. And in 2002, I started to focus myocardial viability in patients with left atrial aneurysm, because in routine clinical practice, more than 30% of patients have a viable have aneurysm. So I want to look at what kind of these patients' prognosis. And we found if patients with viable myocardium, annual mortality is a high 11.6%, which was significantly higher than patients treated by revascularization. And also, you know, the patient with a severe heart failure usually revascularization in compared with medical therapy can significantly improve the survival. That in 1997, the study, and 2009 later, 10 years later, is a similar result. But we know the medical therapy had a significant big progress, improve the patients treated by medical therapy. So the 37% survival in comparative 54. And recently, because 2016, I moved another hospital. We, you know, we have more than 3,000 patients, ejection fraction less 35%. We look at the image for the result. Patients treated by medical therapy, 4 years survival only 33%. So it could be significantly improved by revascularization. But how to identify these kind of patients? Because the patients, you know, it's many factors to decide the patient outcome. So we look at the imaging, the patient with viable myocardium, and 1 year survival, 79%, and 4 years, 49%, which was significantly lower than patients treated by revascularization. And the patient survival by medical therapy and with viable myocardium, which was similar with before 1997, 2009. So it's very important to how to identify these kind of patients. And we look at one case, 63 years old, 3-vessel disease and severe heart failure, and a large amount of viable myocardium, and ejection fraction only 90%, and large volume. And the patients treated by chronic bypass graft. And during the procedure, and the blood pressure gradually increased. And 9 days after surgery, the ejection fraction improved 42%. So it indicates the viable myocardium is correct and identified by pre-surgery. And also left ventricular remodeling, is very important for contribute to the heart failure. So how to identify the left ventricular remodeling, is have a different kind of techniques. But nuclear cardiology, we have the gated study. We can, analyze this kind of information. Look at the one imaging by the peak in our lab. We can dynamic imaging to analyze the changes in myocardial perfusion and the metabolism, and also ejection fraction, and also for the volume. It can be enlarged and the ejection fraction is decreased. And also the wall motion, wall thickening, the extent much enlarged. So for the animal study, we can dynamic evaluate the perfusion viability and also ejection fraction, and also the remodeling information. So we can have more information to analyze pathophysiology information. So in clinical practice, the patients usually coming to hospital is a severe heart failure. So how should we combine the hibernation myocardial information and remodeling information to identify patients who could be benefit from revascularization is very important. Look at our data. If patients no hypernation, no remodeling, and remodeling we use 70 millimeter and per square meters, and the patient's outcome very good, and 98% 4 years survival. But if both positive hibernation and remodeling has a severe cardiac death. And we look at the treated by different treatment strategy, medical therapy or revascularization. If no viable myocardium and with remodeling and treated by medical therapy, have the survival is lower than revascularization, but no significant difference. However, if a patient with a viable myocardium without or with remodeling and the patient treated by revascularization could significantly improve survival. And if a patient treated by medical therapy, 42 months is a very low survival. And if both is a positive and only hibernation, 62%. So it's very important to combine the both information to guide the clinical decision, improve the patient's outcome. Let's look one case, and 60 years old male, and no ischemic stress, rest study, no ischemia, and severe heart failure, and remodeling very severe, and the PET study, no viable myocardium in LD territory. So patient treated by medical therapy, and the follow-up 48 months, there is no event. And also, how long time hibernation myocardium could be improved after revascularization? It's a lot of factors also. And we look at the old study, mismatch extent was a correlation with the delta ejection fraction improved. And we used the 27 patients and found the percentage of hibernation is a total peripheral defect. How much percent of hibernation among total peripheral defect? We found 55% could predict reverse remodeling, and also negative correlation between hibernation percentage and change of add diastolic volume was observed. So it means the more the hibernation among the total peripheral defect, the better could be reverse remodeling. The patient number is not big enough, but we still continue for this kind of study. And also in Angel Hospital, is the most severe heart failing patient come to visit our hospital. So the patient are very severe, and with this case, and is a large amount of viable myocardium, and And the follow up, we can see the anterior wall, septal wall, the perfusion much improved, but inferior wall and the lateral wall not much improved. So it's 6 months. And we look at the ejection fraction, 30% improved to 70%. It's not a big change, but for the reverse remodeling, EDV from 330 milliliter and decreased to 49%. And we look at the regional thickening wall motion, we can see the regional thickening in anterior wall, and it is gradually improved. It's 6 months. And look at the 9 months, and the patient, no difference, and the phase analysis is worse. So we can evaluate the outcome and evaluate the treatment effects. So it's a very important information for guide the patient to continue treatment. And also we know even hibernation myocardium is a long study and many clinical and experiment study, but the mechanism still is not very clear. And we did some study, and the ischemic cardiomyopathy, we observed the myocardial flow reserve in remote area, viable, non-viable area, and we find the patients, the regional with viable myocardial flow reserve was significantly lower than remote and also volunteer. And also in regions with viable myocardium, FDD uptake by hibernation myocardium was negatively correlated with the FDD uptake, is negatively correlated with myocardial flow reserve, and means the hibernation myocardium want to maintain the viable, so can be increased uptake, FDD uptake. So it's the result is very similar with the previous animal study. And also we know an interaction and the interaction between heart failure and the disorders of the brain has been widely recognized in past decade. However, the underlying pathologic mechanism of brain dysfunction induced by heart failure is largely unknown. So the global glucose metabolism in the whole brain and in cognition-related regions in heart failure patients remains highly elusive. So we did some study, and the patients grouped by hibernation myocardium and ejection fraction, and the 5 groups. In the whole brain SUV metabolism have a significant difference among different groups. And also if a patient with severe heart failure and the ejection fraction very low, and the whole brain SUV is significantly low than this group is significantly lower than patients volunteer. And also we did the regional SUV-RS. We found in most cognition-related front areas, and the hibernation myocardium was positively correlated SUV-R. And let's look at the 2 cases. One case with a large amount of viable myocardium, ejection fraction 22%, and a severe remodeling, and the whole brain imaging we look is good. But another case, and the ejection fraction 50%, and the large myocardial scar, and the metabolism was significantly decreased. So brain metabolism in the whole brain was significantly reduced, but maintained in cognition-related front areas in heart failure patients. And so it's just the primary study. We are still continue to analyze data and collect more patients. I have take a few slides to introduce my department. We have the cyclo, and we have a micropad CD, and also we have expert to for establish the animal models. So we did a lot of rat, mice, and the pig study. And this is a FAPI, and this is FDTPA for inflammation. and with dynamic imaging, like pre-surgery, first weeks, fourth week, and 8 weeks. And we did, we want to evaluate the pathologic mechanism. And also international and national meeting and training course was held by my hospital because nuclear cardiology in China, is a lot of work needed to do. Myocardial profile imaging per year is not a big number, so we have a lot of training costs. And for the practice training costs, for the more precisely, we need to, more physicians and the technicians can be use this technique very well. And also we have a lot of national and international cooperation and help to, for the development.
I will not be burdening all my audience with any kind of hefty images or clinical studies. It's going to be a very general kind of topic for our discussion. That is the quality in nuclear medicine. Okay, let's begin with a small scenario. It's a bright sunny day. You are at work, very happy, and all of a sudden your CEO or director of your hospital, he calls you up and he tells you that he has decided to upgrade your department and that they want to buy a new gamma camera for you. And you, as always, very jubilant with the thought, and you come up with the very good words. And then you are given this task to come up with your suggestions on this task in about 2 days. So how do you do? What are the things that you will be considering? How we will approach this kind of decision? Now I totally understand that it's not a very simple procedure. The one that I will be showing the couple of slides next, it's not as simplified as it seems to be. But let's try to like go around all the bureaucratic hurdles and just try to live in an ideal world. What are the things that you will start with? Obviously, you'll be doing some brainstorming upon it, and you will be thinking of a lot of things, a lot of starting with the camera type. What kind of a camera do you need? What is your department's requirement? You need a planar small field, you need a dual head, you need a SPECS system, or you just need, without them, you need a dual head or triple head, whatever. Then you'll go after the companies, you'll collect data on the companies, you'll ask a lot of companies who are supplying those kind of machines. You'll go through their brochures, their data sheets, camera performance specifications, and a lot of things. You might even consult with your peers who already are using machines from those particular companies. You want to know about the company, the level of trust that you can have in that company, the innovative skills that the company has, the staff training to which they agree upon, or after sales services, all these things. And then comes the $1 million question. You tag it with your budget. Can you afford this kind of machine, or which kind of machine that is suitable for you? Now, just going through what these 3 steps that you did in, what actually performance did you do? First of all, you looked into the specification of any particular camera that you were looking for. Then you kind of made a comparison in between the companies along with their measurable quantities, and we came up with some kind of a result with it. Then you had an overall perception about that company that we discussed under that by talking to your friends. So how reliable is that company, and should you go for it or no? Coming back to our CEO, after 2 days, he catches you again in the corridor of your hospital and asks you, where are we with the gamma camera? And you come up with a response that you have chosen a camera with the best quality. The key word here is quality. All of these things that you did in these 2 days while you looked at the specification and the company things and everything, you were basically informally assessing quality. You were making up your mind to choose the best quality camera. So what exactly is quality? Quality is an attribute that is what you assign to a system or a process or a machine. That is something that you give it to, you put on that tag, and it combines both the intrinsic characteristics, the specifications, the company issues and everything that meet up to your expectation. This is the quality informally if you define it. And a more practical definition could be that it is the capacity to satisfy all the requisites that you may have as a customer or all other involved parties that are called as stakeholders. These parties could be like your patients, the management of your hospital, everything. So it's the product of all these things that satisfy all the needs or requisites that you may have. So it's quality is basically a practice that comes with the expectations and demands that your clinician who is referring the patients to you, he has from you, the patient who is coming for your scanning or therapeutic services to you, he places in you, and then it's yourself. Are you delivering quality practices or not? Are you giving the quality services or not? Because like any physical products that you come across, they have a tagline of quality. The services part, the services like nuclear medicine service is a service, it's no exception from all this kind of paradigm. So there's no escape. You have to stick to a quality paradigm and you have to practice good quality in your department. So the very basics, we start with the quality control. It's the basic component around which the whole quality program builds upon, and its importance cannot be toned down, as we already have had a workshop with the quality control also. How do you define a quality control system? Well, it's a set of protocols and a system where you implement and try to maintain and improve the quality of your machinery and your services. You monitor, you evaluate, you keep a maintenance check for all the equipment and come up with your results in a defined manner. You measure them and you see if they are in a control level or no. Next comes the quality assurance. Quality assurance is again, it gives you the confidence in your system and your services that if there is a set agreed standards, international standards or national standards, that your system and your services conform with them. Next come the quality management. It umbrellas both quality assurance and quality control, and it's basically not other than the management function that you ensure and that there's a quality policy that is in place and your department and your institute is practicing that. That is where the quality management comes in. Coming back to our nuclear medicine services. So any patient walking in always thinks, and most of the other of your colleagues, they were not in nuclear medicine, they'll think that you are just give a primary service, that is either you diagnose something, you perform diagnostic services, or you just give the therapeutic services, you offer the therapeutic services, and that's it. That's what nuclear medicine services are. But instead, in addition to these primary services, at the departmental institute level, you're performing a lot of secondary services also. You're looking into your facilities. What kind of facilities does your institute harbor? What kind of patient care are you giving? What is the waiting time for your scans or therapeutic list? How well is your staff equipped with the current competencies? What is their experience level? How do you optimize your process of from the patient coming in to going out of your department? The radiopharmaceuticals, quality control, which one are you using? How are you disposing them of? What are the techniques that you can do in your department? Your instruments, are they at par? Are they working properly? So these are all kind of the secondary services that definitely translate into your primary services in delivering the services that you are offering to your patients. So what are the key areas of quality management? The clinical side, what kind of services, how you approach your patients, what kind of outcomes that you come up with, the technical procedures that regard from other than the patient, what are the other procedures that you do? Like it could be from the administering the radiopharmaceutical up till the waste management protocols and everything. How are you dealing with those procedures? How do you prepare your patients? Is it just that your patient comes in and you do the scan, or is there a proper training program for the patient that they have their directions how to come prepared for the scan or the therapeutics? Is that in place? Do you have a proper quality assurance or quality control procedure in all of your departments for everything that you are doing? How do you report? How do you formulate your reports? How do you ask the patients to follow up? How do you ensure those follow-ups? These are all kind of the key areas that you come across with when you're talking about quality management. So in the clinical, you get a patient, it comes with a history, the patient comes with a question, the referring physician has something for you. Now you have to decide the kind of radiopharmaceutical, the type of study that you have to do. You have to do planner, you have to do 3-phase, or what you have to do delayed imaging, static, that is up to you. You have to decide the radiopharmaceutical and the process. On which machine do you want to do that? You want to do it on a planner machine, you want to do it on a spec CT, or this? These are the things that are the beginning of this process. The procedures that you adopt, was a proper patient history taken? Were all the key factors that you wanted to know, were they recorded? What is the diagnostic question of your referring physician? Is there any diagnostic question to begin with, or is it just do a thyroid scan? Or is there any question behind why do you want to do the thyroid scan or a bone scan, or for that matter, any FDG scan? Appropriateness of investigation. This is a very important point, and most of the time this is ignored. Well, I can say to most safely, I can say that in Pakistan or in a lot of other countries also, appropriateness is very important. The machinery, the technology that you offer, it has to have a very proper use of it. You cannot just take any walk-in patient and start doing FDG scans for everyone, or for that matter, if you get a PET MRI and you start doing PET MRI for all kind of patients who even walk in with a headache. So that is a very important, because this inappropriateness loses the value of your services and the value of the machine that you have. Contraindications: patient is pregnant, is a children, it has come with a PQ scan. What kind of contraindications that you have? These are all these is just example, and these kind of, you have to know all of these things when you are ensuring a good quality service. Planning for that procedure: do you have reliable procedures in place? Do you know what the patient is supposed to do when he or she enters your office, and when she or she leaves your office, and where are they supposed to go? And do they have their files already in place? How do the system works? You have to plan these kind of procedures. You have to inform the patient with all the procedure that is gonna happen. It's not just the patient comes and you just direct the patient to go in a certain room and someone will tell you what you have to do. The best approach is the patient needs to know what you are doing, or you're going to do, or what kind of test or things that you're going to do with the patient. Patient preparation: first of all, if you have dispensed any leaflet in when you book the patient, was the patient prepared? Does the patient know how they have to come? They have to come fasting, or they are not coming in fasting? Any things that you have to bring with them, the medications that they are using, have they been withheld? These kind of things that you have to note down. So there has to be a whole paradigm that you have to follow, and you have to have all the checks and balances and the decision making points in throughout your cycle where the patient is coming and going. Like if you have booked a PRRT, then this is a sample of one of the hospitals that what they follow, and how obviously your protocol has to be different, and you have to like have this in black and white, crystal clear. And why are we doing all this? Just to ensure a harmonization in our process for each individual patient. The clinical procedures, the quality with the clinical procedures, the suppliers, the materials that you get, are they of a good quality, good standard, or have you compromised on something? Do you have the proper storage facilities for all the radioactive material and the non-radioactive material? How do you prepare your dosages? Is there have you trained your staff to do that? Is there a proper clinical environment for the patient where you discuss their problems and you address them? Patient handling and preparation is very important. Equipment performance and the acquisition protocols. Equipment performance is your is all your machinery well in their standard functioning mode? Is there any problem? Is the system in control? Is there out of control? These are all things that you have to look into your department. You've got to have a proper waste disposal system. Everyone should know what to do with a radioactive needle, with a radioactive source, how to dispose them of, where to keep them in storage, and how that works. There has to be a proper process for that. IAE has a good nuclear medicine quality control toolkit that is there for reference, and I mean it's available for all the departments, and it's good to have this kind of toolkit and to go through all this to have your systems doing work better than whatever they are doing right now. So International Electrical Electrotechnical Commission. They are the ones that deal with the standards of most of the electrical, not most, all of the electrical equipment that is out there. And they work with the quality control and quality assurance standards for them. They have set specific specifications for all the equipment. And there's a paradigm to be followed, like how you are supposed to do the test for your cameras, how to do the routine ones, how to compare the results, and how to arrive at a decision point to see if your equipment is properly working, or is there something that you have to do and you have to perform some corrective actions. Training and experience for all your staff. Now you have to decide beforehand what kind of nuclear medicine specialist education or qualifications are you looking for. There has to be a set criteria. I'm sure all the departments have that, but you have to be very stringent about these kind of requirements. Physicist, it's very important that you have well-trained medical physicists and not a part-time technologist or some other person who's doing the physicist job. You have to have a physicist who is well versed with all kind of procedures that and services that happen in your department. Technologist. Okay, in Pakistan, I know that there has been a lack of properly trained technologists for a long time, but that's not an issue. Even if you don't have a properly trained staff for that matter, train them, keep their checks and balances, evaluate them either yourself or by one of your colleagues, and keep the record of all those trainings and develop your workforce. Same goes for the radio pharmacist. I am not sure that we have a proper training program anywhere, any degree. It's mostly MPhil or PhD students who work in the specific field for the radio pharmacy, and you hire them as radio pharmacists. But every department should have one. Most of the departments are, again, even if you don't have radio pharmacists, train one of your people and try to impose strict quality measures and try to impose a strict evaluation for that. Arrange CMEs or arrange your staff to facilitate your staff to attend CMEs, but it's not like I did my medical graduation 15, 16 years ago, and it doesn't work that way that I go without any other training, without any other refresher kind of course, and just keep my knowledge to the level where it was 15 years ago. Facilitate CMEs. Data analysis, very important. Go through your processing protocols. Are they specified according to your needs? Are they measuring what you want to measure? Are they measuring everything in the way you want them to measure? Your equipment, is it in order? You have to perform their quality control checks. Is their integrity maintained? Is there all the results well within the specified limit? The accuracy and integrity of the data that you are collecting, that is very important. Is that the true data? Does it really represent what you have recorded so far? Reporting. Now, this is one area I think where PSNM can be of great assistance or great help. What should I can say? Unify the reporting system. There is a set pattern of reports. I'm sure if you pick up random reports from a lot of centers across Pakistan also, a lot of things will be missing from all these reports. But you have to follow a protocol when you are devising a report. Patient demographics, identity, study type, pharmaceuticals. Always come with a diagnostic conclusion and recommendation. This is very important. Objective description of the findings. I mean, writing down just increased uptake.
Dr. Zakir Chirag, sorry to interrupt you, but we are just ahead of our scheduled time. So can you kindly please?
Yeah, just give me, I'm just on the last couple of slides.
Okay, thank you.
Okay, the general outcomes of your studies. Audit yourself, look at your data, look at the things that you have gathered, get feedback from your patients, definitely from the referring physicians, build your confidence for your services. Okay, just going through these. This is a quality management cycle that you can do for all your quality things that you're doing. The main idea is to move forward, to move towards the improvements through a quality management system. Audit yourself. there are two kinds of audits: internal audit, external audit. Internally, you can train your staff and do your audits regularly, or you can do interdepartmental from the departments or from certifying bodies. Let's we can like go through all these kind of, yeah, just the basic definition for what basic procedures and protocols are, and what is an SOP, what kind of documents they are, and yeah, just basic definitions. And we can just go quantum audits. This is a very good tool, again offered by IAEA. Do your audits. These are an Excel sheet based audits. And as far as I know, only one center so far, I think Noori Islamabad, has audited themselves. Rest of departments should also be using this kind of format to audit their findings and everything. This is an Excel sheet for their and how they perform their results. Second last slide. Quality assurance is not a threat. It's just an opportunity. Embrace that. Staff should feel free to report any kind of errors, can create a non-toxic environment that, like we had in the keynote lecture also, build a culture in your department. It should be non-threatening environment. Regularly reward your honesty with encouragements or whatever other means that you can do. Education is the key here, not punishing. Don't punish someone for any errors that they have made. Openness should be encouraged, because if you're not open, you're not reporting anything, the problems get worse. So I hope I have not lost any one of you so far. There's a small poll, if we can run like quickly for 30 seconds, where we can like have the audience participation also. So which of the scenarios would you likely go for? Modern equipment, unqualified staff, old equipment with qualified staff? If you can like spare 30 seconds and we can run this poll. I would just request the host to like, because I cannot see how many have voted so far. So if in another 15 seconds or 20 seconds, we can just stop this poll. And I don't know, can you share the results? Okay. So that was my last slide. Again, thank you so much for your time. And old equipment, qualified staff, thank you, 84%. I don't know who are the 16% very enthusiastic. I think people who want to do. So thank you very much.
Thank you very much, Dr. Chirag. Now we are going to move quickly to our next speaker, who is respected Dr. Humayun Bashir. He is the consultant of Head Nuclear Medicine Department, Shaukat Khanum Memorial Trust Hospitals, Pakistan. He has more than 20 years of experience of nuclear medicine and more than 35 index publications. He is also a member board of Asia Oceania Federation of Nuclear Medicine and Biology, had been the past president of PSNM and chair of first Sino-Pak Nuclear Medicine Symposium. So I would like to request Dr. Humayun Bashir to take up the stage right now. Thank you.
Thank you very much, Dr. Ambreen. Can you see my slides?
Yes, I can see your slides, sir. Please go ahead.
Okay, it's yes. First of all, thank you very much for inviting me to this conference. It's a great opportunity, and it's really nice to see the associations with different societies coming up so nicely with every passing year. So today I'll be talking about nuclear medicine, how to make a formidable contribution. I'm not going to talk about the science and the images and all that. I'll be talking about the perception. As a head of a training program, we all come across people who have queries from within and from outside our discipline, and that's the kind of things that I'd like to address today. So we have to look at a formidable contribution we can make, or we should make as practitioners, as postgraduate trainees, as scientists and technologists working in the field of nuclear medicine. There's a self-image from within, and there's an image from the outside amongst our peers and the general public. Now, two facts. Nuclear medicine is a less well-known medical discipline amongst the medical fraternity and the general public. Secondly, nuclear medicine is a multidisciplinary team, yet it is small in numbers. It's a very limited political weight. These facts are unlikely to change, and we need to make the best of it. Now, what is nuclear medicine? This is a question we often come across. At times, we actually end up being faced with a question when somebody says, "Are you a doctor?" I've actually had come across this meetings in some professional college meetings, because when we're talking too much about science and equipment, people start wondering. So now, if you look at the whole medicine profession, this is from physician's perspective. Our degrees basically talk about medicine, surgery, MBBS or MD. But generally, the specialists or the physicians are looked onto by different categories, like body systems, like cardiologists, gastroenterologists, pulmonologists, or they are disease based, like the oncologists. They can be age based, they can be treatment based, like anesthetists and palliative care physicians. Then there's also the scope, whether one is in a general practice or a family physician or representing a specialist discipline. Nuclear medicine in this broad spectrum actually falls into the category if one is considering diagnostics or one is considering a technique-based disciplines, and that's where we, like nuclear medicine, radiology, and rad-onc would actually fit in. So we have to understand, when a question is posed to us, what an individual trying to understand. Most of the public is familiar with cardiology, gastroenterology. That's a body-based system, a body-based specialist. So when the question is posed to nuclear medicine, we actually start thinking from our own mind, without thinking that we will not be able to answer that which body system actually we treat or diagnose for. We actually do a whole body system thing. And the closest thing to make somebody understand nuclear medicine is that you're familiar with radiology, where they do X-rays and CTs. So we also do something similar to that. Now, recently, I actually had an opportunity to explain the discipline on how I look at it after 20 years of working into it to a broad panel of very senior clinicians of an hospital administration. And they were focused, they wanted a brief thing, how would I explain the life of a nuclear medicine consultant? And that's what I came up with. It's a quintessential tertiary care technology incentive specialty, which requires highly skilled multidisciplinary team to deliver. A day in a life of a nuclear physician is like a long haul. You have to be around, things are happening in the slow pace, quite unlike what happens in radiology, where things are, there's a very rapid flow. The patients that come to nuclear medicine service are there for several hours. So there's a time for long association, building up a sort of relationship with these patients. And it always takes 4 to tango in the nuclear medicine service, whether it is basic, conventional, cardiology, or even PET. This actually went well with that panel. This is a process map for nuclear medicine. I won't discuss this because the HR just very nicely elaborated this whole thing. Now, the discussion about what nuclear medicine is, the next question which automatically comes into in any conversation is, what's the future of nuclear medicine? This debate has been going on for quite some time. It has become very extensive in the last 20 years, more extensive in the last 10 years, since hybrid imaging has established itself across the globe. So there was a special edition from JNM in 2019 which covered all these aspects. So this simple image shows the areas, how we look at it, their strengths, their weaknesses, their challenges, and their opportunities. And this is a very comprehensive way of looking at it. And in the strengths, we are all familiar, basically it's the nuclear medicine community, which we are addressing. In the weakness section, you can see there's lack of strict licensing. There's actually, here it mentioned lack of strict licensing requirements. They're actually over licensing in most of the countries, but of course that's a factor. Insufficient training into newer things, nuclear medicine community. The idea is one of the reasons that I've picked up this topic is that how the community looks at itself and how we actually make the use of it. This discussion about takeover and the tough situation with different disciplines in radiology and cardiology and other interventional disciplines. This is the debate which I said has become very extensive in the last few years. There's a fear of loss of ownership, and this RVU mentions about the financial compensation as it is looked at in the United States, but everywhere money is an important factor. The newer opportunities are, of course, theranostics and the new markets that are coming up. So this very nice article actually summed up their points with these few lines. The future is bright and challenges exist. It's a viable discipline. It's not going anywhere. It's one of the most convincing examples of precision medicine, which is the future. However, what's required is revision of how the training is done, which is actually happening. I'm part of it in Pakistan, and I'm familiar with system everywhere else, and so is everybody else. And we know that training systems are changing across the globe. They have changed significantly. They're still, they're changing more towards meeting these needs. There will remain some variations. In some countries, it's 6 years. In some countries, it's 4 years. But it will be within 4 to 6 years, and that variation we have to accept it. Now, in this era of multidisciplinary patient care, now as far as the perception within our peers is concerned, the best way is to reach out to our clinicians, which we always do in our setups. Most of the nuclear medicine setups are, especially in our country, and they're based around the oncology setup, so close to oncology setup, so working with a system which is primarily an oncology setup. So that's where our most interaction is. And then there are other disciplines. We come across surgeons through our thyroid component. We come across cardiologists. So I'll briefly touch upon these. We have to befriend all these clinicians because that's from where all the bread and butter comes to our specialty. Now I'll just quickly go through images, but basically focusing on the clinicians that we are referring to. So oncologists are our main referring clinicians, especially with PET. With a busy PET service, almost 50 to 60% of clinical work can become PET. Now at our institution in Lahore, Jagatanand, they put 2 scanners, almost 50 to 60% work will be PET. We have already actually experiencing that. FTG is the main tracer, but very swiftly we are moving towards new tracers. Primary Gram68, another rounds on the line. This is an image for gallium PSMA, prostate, a major disease burden globally. Bone scan has been a key component of management, diagnosis and management of prostate cancer. Now we've got PSMA, that's the new kid on the block with theranostics with it. Again, neuroendocrine tumors, that's where we actually get a chance to be into the multidisciplinary gastrointestinal teams and pulmonary teams as well, MDTs. So that's an area, that's where we actually go back, with the GI and other specialists. Cardiology is a major area, although much of it globally is also done by the cardiologists themselves, but this remains a turf which is important where we meet. Even in cardiology now, there's an increased trend of multidisciplinary meetings, and all those people who actually get a chance or have had the chance to attend these meetings, they know that when a question is sent towards nuclear medicine or for a nuclear cardiology, there's a specific query what they want to be answered. The treatment beyond a certain point actually depends on that, so the position is very critical. Orthopedics. This is, bone scan is still the bulk work we do. Hybrid scintigraphy have completely changed our perspective about it. It has become very interesting. Now there are key areas much beyond just picking up metastasis. There's more bone lesion characterization that's required, which requires very good knowledge at the back of it, but at the same now there are pathways looking at it. Prosthesis, as we have an aging population all over the world, these areas are very significant interference. The orthopedic surgeons, it's always good to have a liaison with orthopedic surgeons. In your hospitals, in your institutions, in your community, reach out to them, and we can actually offer them what new hybrid scintigraphy actually offers. Endocrinology is almost part of our practice with thyroid related diseases, and then beyond we have parathyroid tumors which we can localize, and we have a key role. This is where we meet not just the endocrinologists but also the thyroid parathyroid surgeons. Sentinel lymph node, nuclear medicine scintigraphy has a key role in that. And in our COVID situation last year, when the hospital was restarting everything, one of the first surgeries they started was breast surgery, and in that it was pivotal for the nuclear medicine department to be able to provide the central scintigraphy. So again, we are niche areas where nuclear medicine comes in, and we are working as a very comprehensive multidisciplinary team. Sentinel goes beyond breast imaging into GU and GI imaging as well now. Urology, renogram, it hardly has its own replacement till now. For urologists, not so for nephrologists. But here I would like to mention that in pediatric nuclear medicine, as conventional nuclear medicine is concerned, almost 60% is around the applications of renal applications of nuclear medicine.
Dr. Humayun, 1 minute, please. Can you open your video camera, please, so that the audience can see you as well?
Okay, I actually, okay. It says you cannot start your video because the host has stopped it.
Well, I can ask the host to stop it then, to start it then. Okay.
Yeah, please. Thank you. Okay. So nephrology, so pediatric setups that across the country, especially in our country and other countries, well, they should actually have nuclear medicine departments, and they should actually push for having one on their own turf. Uh, okay, neurology is a very important area, and this is one of the challenging areas. All hospitals, unless they have a very comprehensive neurology team and a very comprehensive neuroradiology team, that's where neurology, molecular imaging or nuclear medicine comes in. But this is again a developing area. I remember when I was doing my PET training at that time, we were just, we had this discussion with one of our mentors that why don't we do that many neurology scans? It's the treatment. The day we have comprehensive treatments for Alzheimer's and all those things, which are all already now in the market, that's where the imaging will become all the more important. Just diagnosing is not enough. So that has come a long way since that discussion I had with my mentor. Um, now, these are very two important nice papers published in JNM Technology 2008, which actually covered the infrequent pre-performed nuclear medicine procedures. I'm just put the images here, like decrocintrography, left to right shunt, right to left shunt. Right to left shunt has become more important since we have these TheraSphere and these imaging. Cinti memo is quite out because we have got PET memo, but of course it is the procedure is there. Heat damaged RBC for looking for splenic tissue. They also have the second paper in which they talk about CSF shunt, lung perfusion quantification, brain death studies, testicular torsion studies, salivary gland studies, and lymphoscintigraphy. These papers are good for actually trainees to look at because you won't come across these studies that frequently in your training, but these are very comprehensive papers which cover the technique and technology of doing these procedures. But again, nuclear medicine setups which exist in a general hospital get more opportunity to offer these particular tests, for which of course one needs to reach out and offer these tests to specific disciplines, and then of course they'll get a referral for that. So the opportunity to expand or to make friends in an oncology setup are different as compared to a general hospital which has a nuclear medicine department. Now, this is from the same edition supplement of JNM, Nuclear Medicine in Wall Street and Evolving Relationship. Now, this is very important. This article talks about the promise which is offered by the new theranostics or radioligands for therapy. And briefly said, now the Wall Street, that's the business world, the large pharmaceutical companies, because that's what the issue. Unless the thing is cost effective, it is unlikely to be marketed properly. These radioligands offer something completely new, which is as good as or is actually better than what the conventional chemotherapy and molecular therapies offer. And they've actually concluded there's an urgency to work to do this work because patients are actually waiting. So this trial I've just pasted at the bottom of the slide, which is published in early February this year, late February. So this is actually now the business market is also looking at the progress that nuclear medicine actually can make. Technology, this, just to, have sort of a flashback, whole thing grossly changed when PET-CT came into commercial and clinical use. This was the year 2000. It was, the image of the year initially. On the right, I've put the first PET image back in 1970s, done by Dr. Alavi and his team. But in 2000, hybrid scanner made PET a success. Now we have come even further. We have our Chinese friends here today, and they've come up with a remarkable machine, which actually does a whole body scan in a beautiful manner. And according to Dr. Lavi, the whole body machine is another quantum jump in medical imaging. So after 2000, now thanks to the Chinese stepping into this whole high-tech medical imaging stuff, we are into a completely new era of actually whole body scanning, which in which a scan can be done much faster with much lower dose and with much better resolution. So the technology has actually delivered. Now, this is an article by a clinician who was Dr. Stephen Larson, who was one of those individuals who were awarded the first American board in nuclear medicine back in 1972. So he's written this article in 2019 at almost such a long career having spent in nuclear medicine. And so he has actually this very inspirational article that if you want to look for an inspirational career, this is the one to choose. It's a good article. I'll leave everyone to read it. The major point that he makes in this article is if we are truly going to attract the best and the brightest, The leaders and mentors in the field must educate themselves in both research and clinical, diagnostic, and therapeutic. And by educating ourselves, what we mean is that the newer technology has come up much faster than probably our training programs. So there's a lot of opportunity, but there's a lot of demand to actually learn and then impart that knowledge and what we gain to each other. Driving the future of nuclear medicine. In this article by Ken Herman, they actually just conclude what we've just said. Our specialty needs to embrace the opportunities and overcome the challenges. I've listed the equipment that's already available in our PET CT, SPECT CT, PET MR. Theranostics is there. That's basically a combination. SPECT MR and ultrasound gamma probes are already on the cards. So it's a very good time, as Professor Yan mentioned in his earlier talk. Now, just going towards the conclusion, what's in the name nuclear medicine? Now, this is something very personal. I'm a nuclear physician, and that's what I know. I don't know anything else beyond that. What we do within nuclear medicine is a diverse work, which has changed even in the last 20 years that I've practiced. It has changed more so for people who are even more senior to me. But lately, it feels that there's been an attempt to rename ourselves, which is not required. That's what I personally feel. And just to give you an example, I've put comparison with the term orthopedics. It was coined in 17th century. It means straightening. The ortho word means straight or to correct. Pedics mean rearing of children. This discipline started when they were treating straightening of the bowing bones in children. Now, since the 17th century, orthopedics has come a long way. It's a completely different discipline. It's got so many different divisions. We all come across it in various capacities. The title remains orthopedics. Children might be a very small proportion to their own population of the orthopedic word, but nobody ever thought of renaming itself of themselves. Similarly, nuclear medicine is the discipline. In this, they are diagnostics, they are therapeutics, they are non-imaging procedures, they're imaging procedures. There are hospitals, there are systems in the world where even ultrasound is done in nuclear medicine as a routine, as part of training. So all that is part of our platter, which is increasing, which is expanding, and so it be. But the discipline remains nuclear medicine. That's my personal feeling, and I just thought that I'll address it here as well. As far as our path is concerned, it is uncommon, it is not unclear. We were able to use the images to address and to present to patients and our referring clinicians what the technology of that time provided, be it 1960s, 70s, 80s, 2000, 2001 to 2021. So there's nothing unclear about it. It is an uncommon path, and we have taken it because it is an uncommon path. And that's the benefit of it. And just to conclude, this is a quotation from Quaid-e-Azam. He made it while addressing to the Air Force. That's not the perspective here, but it's, sort of addresses our point. You'll have to make up for the smallness of your size by your courage and selfless devotion to duty, for it is not the life existence that matters, but the courage, fortitude, and determination that you bring to it. That's what we all do. In fact, everybody does that. In every discipline of medicine, people work hard, work with passion towards their goals. Now, working in a smaller community, which is so diverse, which sits on the edge of technology, in fact, the technology is going faster than the clinical application. In the words of Dr. Thomas Bayer, who actually is very much involved in propagation of PET MR, he says the technology has already delivered. It's the clinicians who actually have to catch up now. So that's where we actually stand. It's a very good time, and so we have to understand what we can offer to the to the patients and the healthcare system at together. This is just a picture of my nuclear medicine team that I work with in Shaukat Khanum, Lahore, and Peshawar, and the trainees that we have. Is one of the largest programs. It's a privilege to work with this team and to be able to do some real good nuclear medicine in the broader picture of the discipline. Thank you very much.
Thank you, Dr. Mahipashir, for such a nice talk. And literally, it was these are the words which every nuclear medicine physician in Pakistan right now says, that there is no need to change the name of this specialty. Thank you for emphasizing that. Now I would like to introduce our last speaker of the session. Sorry, second last speaker of the session. He's Professor Geoff Surrey, Professor of Nuclear Medicine at Charles Church University in Australia, and he has more than 160 more than he has attended more than 160 conferences and almost presented very nice papers over there. And he has a significant footprint in artificial intelligence in nuclear medicine through journal publication, invited conference and webinar presentations, teaching and research. And today's talk is on the same topic, that intelligent imaging and developing a machine learning project. So now I would like to invite Professor Gyop Sari for his talk. Thank you.
G'day, it's Jeff Curry here, and I'm just going to deliver this presentation that provides an insight into how to develop a project in artificial intelligence, machine learning and deep learning. It's not really designed for those people who have experience in the applications of artificial intelligence, machine learning and deep learning in radiology and nuclear medicine. It's really designed for those people who have a bit of an interest and not sure where to start and want to dip their toe in the water of artificial intelligence project. So I hope that provides a perspective and it meets the needs for that intermediate or beginner level. There's a publication that you can also read that provides an early introduction to the machine learning, not so much the deep learning, but the machine learning projects. Now, artificial intelligence has moved in at such a fast pace and offers so many exciting opportunities that the inclination for many people is to just jump into something big. But a more sensible and sustainable approach might be to start small, learn, build momentum, and use the internal knowledge that you're developing to then grow an artificial intelligence strategy, not only for your own research, but for the research program that you might have at your institution. So individuals or groups that are eager to build their own artificial intelligence footprint tend to target their efforts in creating, world-changing, top-end deep learning algorithms. And they're very difficult and they're very expensive. The real challenge is not getting started in artificial intelligence, it's getting started without bursting the enthusiastic bubble that people have for artificial intelligence. So for example, if you consider, I guess as one example, a very keen group of collaborators who want to develop a deep learning algorithm to stratify asthma and silicosis on ventilation lung scans from disease-free scans. But they've got no artificial intelligence experience, limited funding, and to be fair, little insight into whether the lung ventilation scan has the characteristics or the features that are capable of differentiating the pathology from normality in the first place. A lot of time, energy and money could be wasted before the project failed. Even if the deep learning provided some stratification, humans will not have learned anything because we don't understand what happened in the magic box. So for me, the first step is to determine whether there's a problem to start with and whether artificial intelligence has the capacity to be part of the solution. And the better approach would be to use the wealth of information that we have from our large patient series with known outcomes that include radiodynamic features that we've extracted from lung scans and converted into data in an Excel spreadsheet, for example, and then feed those features into a machine learning based artificial neural network. Train it on what we know with a binary grounded truth that the disease is there or it's not there. And in doing so, the artificial neural network will identify specific inputs or features that individually or collectively provide the highest predictive capability for disease. It may reveal that the lung scan plays an important role, or it may reveal that it plays no role at all, but you haven't wasted time and money with the deep learning to uncover that. So in the case of the artificial neural network and machine learning showing that the lung scan plays an important role, then what that does is it actually provides justification to then move into a deep learning and convolutional neural network process. And it might even provide justification for funding for the same. But in the case of the latter, that you've actually avoided wasting time, wasting money, and avoided going down that deep learning pathway and move on to another project. So for those that are considering projects in artificial intelligence or trying to create a footprint for yourself or your department, A few dot points to think about to get started. Consider a problem where the solution provides a really good outcome and quickly. To use that momentum to have an early win and build not only success and a footprint in AI, but also interest from other people in what's going on in your artificial intelligence environment. Avoid taking on high investment, so projects, so things that require a lot of time, a lot of resources, a lot of energy. You can burn that out really quickly, and in particular a lot of funding. So if you need a lot of funding to get a project started, you may not get it, particularly if you don't already have an artificial intelligence footprint. And so if it's dependent on that funding, well, then it just sits idle and never gets done. So avoid those high investment projects that provide no reward for a long period of time. You're just going to burn all your energy and your interest. You need those early wins as per the first dot point. Ensure the outcome's not trivial. So there's a lot of projects that are very successful around artificial intelligence, machine learning, and deep learning. But people go, at the end of it, they go, well, so what? You know, like, you show that it works, but, you know, it's not going to change practice. It's not going to change what we do because the results are trivial. So think about the outcome itself is going to have an impact. It's not a trivial outcome. It's something that people can use. So it addresses a problem that has that impact and will generate further attention with success. And that then drives enthusiasm and energy and time and money and all those other things. Focus your efforts on projects that tangibly connect to radiology or nuclear medicine rather than peripheral areas of interest. Now, you know, tangibly connect could be some of the business practices that we do, but if your project is purely built around image recognition and you're using non-medical image data just to prove that you can do something, then you're probably not going to generate the internal interest and funding that you might think. Ensure your team is comprised of credible colleagues internally and externally, and if that means recruiting the right people, then do that. Build those collaborations. So what's really important is to say, well, I don't have all of the expertise, so who do I need to fill those gaps? And make sure you actually get people that share your level of enthusiasm and your level of trust with collaborating in research. It's like building any other collaborative relationship. So recruit a team that's comprised of complementary skills. You don't all, if everyone's thinking the same and everyone has the same skill set, you're not going to get the project done. You want people that actually look at the problems differently, that bring different and complementary skill sets to the project, so that it drives enthusiasm as well as having those capabilities that can accelerate both the project and the resulting momentum on the other side. So how do we go about developing a project? So when we develop an artificial intelligence strategy for your research team or your department, it's not an overnight journey. Don't expect that an exciting project involved today in the tea room discussion to have a clinical impact anytime soon. You need to consider things like the scenario where a data-rich department, you might be a data-rich department, that can train an artificial neural network or a convolutional neural network to perform a particular task, and then validate that algorithm can occur fairly quickly. So this scenario represents almost all of the current literature that's available in radiology and nuclear medicine. So when you're actually looking at what's available in those journals, many of them are just validating, building, training, and validating, testing those neural networks. They're not inference stage. They're not actually applied to the actual real world. And so when you look at the number of FDA-approved algorithms that are being commercialized, it's a very small list. It's a very short list. And so even though you might have an internally valid project or an internally valid algorithm that's driven on your internal data, and had success with your training and validation, provides an algorithm that can be reliably perform the prescribed task within your internal environment, but it may not have that external validity. So the process to get it externalized and commercialized is a much more difficult proposition. So consider, and I know this is a nuclear medicine scan, you could do the same thing for a CTPA or similar. It's a very simplified image because it's only got one ventilation and one perfusion image rather than the whole set of data, and typically we'd do it as a spec study. So it really is an oversimplification just to make a point. But you can see that what I've done is I've displayed the ventilation, the perfusion scan, and then two things. The first thing is a defect probability that's driven by your deep learning algorithm. And so on the ventilation scan, it identifies that it's improbable that there's a defect. So it's just a color-coded risk score or a risk of a defect existing. And then on the perfusion scan, you can see that there's a couple of areas where there's a high degree of certainty in red that a defect exists, and a few probable areas of defect as well. And so that's a nice, easy way of demonstrating not only the defect risk probability, but also highlighting visually where the algorithm is seeing or looking at in terms of defects. So that could be then correlated back. And then based on that defect probability, providing and the defect probability difference between the ventilation and the perfusion, you could then actually generate a numerical score that's based on the probability of the patient having pulmonary embolism. And that would be a really neat way of summarizing your deep learning outcome. And this is just another mock-up that, and there's a couple of sites that have actually done something very similar to this that are not a mock-up, but actually for their patient database. And so looking at a bone scan, a whole body bone scan is someone that's looking for a metastatic spread of breast or prostate cancer. In this particular case, it's a prostate cancer patient. And the auto segmentation of the artificial intelligence algorithm using a convolutional neural network identifies normal tissues, so green being bladder and kidneys, identifying non-normal bone uptake, but not just non-normal bone uptake, but also identifying the intensity relative to what it had learned is normal in the training phase, and giving those color codes based on suspicious versus highly suspicious weather versus something that's relatively certain. So you can identify the degree of certainty around metastatic lesions, but also to then roll all that together to provide a cumulative metastatic burden score. So we need to roll on from there and start to think about how we would actually start to work all this together. And to work out a project, particularly for deep learning, we need to start to think about the code that we use, the frameworks and the libraries that we use. So this is just a schematic representation of the relationship between our hardware in the outside with the green. So you need a CPU, but you need a GPU or a TPU, so a graphic processing unit or a tensor processing unit to be running your deep learning algorithms. The frameworks and the architectures, the libraries that feed the tools that we actually use, the databases themselves to provide the deep learning solution, and of course the language that you use is Python. So this is geared for Python. So we've got PyTorch and NumPy and other TensorFlow and Keras feeds into Python language as well. So let's talk about Python. Python is a high-level open source code. It's fairly simple. It's intuitive programming language that can be used for direct coding of machine learning and deep learning, or the source code for things like Keras, a base network development. So that's an application training interface. It's not the only programming language used for artificial neural networks and convolutional neural networks, but it's probably the most common, and certainly it's the most accessible and usable for those early developers. NumPy is an extension package for Python that allows algebraic functions, Fourier transformation, integration of Python code with other codes like Fortran and C. It's a little bit like the scientific calculator being added to a standard calculator. So in effect, it adds that degree of functionality, and you'll see where we actually integrate it in when I show you some code in a few minutes. So we should look at frameworks and libraries, and I've provided all of the links to the various websites that you can download these resources. So Keras is a deep learning library that runs as an application programming interface for Python in conjunction with TensorFlow. PyTorch is an alternative open source library of tools for training-phase platforms. TensorFlow itself is a graphics-based computation platform that stores data as objects or tensors rather than integers or strings. It's used as a back-end platform for convolutional neural network development, but it can include Keras for broader applications in training phase of the process. So the framework itself and associated libraries might be described as an ecosystem, while the architecture and databases are the landscape. And I use those terms throughout other presentations. So CAFE is the University of California, Berkeley's deep learning framework, and is useful for those that are a little bit more adventurous with their deep learning research. Knaimi is a deep learning analytics platform for convolutional neural network development, training and implementation, and integrates with Keras deep learning architecture and also with the TensorFlow machine learning library. Theano is a similar library for, like a scientific extension of the Python, similar to Python and NumPy, where it adds the scientific calculator. So it's like a scientific extension to these packages, in particular Keras and TensorFlow, with the additional features associated with optimization and speed. And then there's other things like deep learning, 4J. It's a Java-based open source deep learning library that can be integrated with Keras and Python. There's Pandas, which are powerful data analysis toolkits that are used for Python code. So essentially it's a library of tools for those using Python for data analysis. And this is just a very short list of what's available. So let's look at a deep learning example. A useful starting point for exploring the convolutional neural network and the deep learning is using commercial development environments. So rather than actually trying to program AlexNet or GoogleNet yourself and trying to learn the code, then what you can actually do is use some of the development tools. So there's numerous tools that are available, but there's two that I'm going to recommend here. The first one is the MATLAB Deep Learning Toolbox from MathWorks, which is useful software program to develop and deploy convolutional neural networks for the novice. And you've got the web address there, and that's downloadable onto your computer. It's useful on your computer to make sure that you've actually got a TPU or a GPU. And the gaming computers, so just if you wanted to do some deep learning things on your own computer, you need some speed about it, so that you got some neural processing networks on some of the newer computers. But if it's a computer that's set up for gaming, then it's going to have a reasonable sort of a GPU and processing tool. So those gaming computers tend to be good or okay for desktop deep learning applications. So the second tool is the Colab, which is obviously short for Colaboratory, which is a convolutional neural network development environment that uses Python language with TensorFlow. And basically it's a platform that allows the code to be developed, run, and shared via Google Drive. So in this particular case, you can be operating with a standard computer with a CPU, no GPU, no TPU, because it actually runs from the Google Cloud, and there's no cost, it's free. So it runs from the Google Cloud, and it actually uses their GPU and TPU. So it means that you've got more powerful tools at your disposal without the cost. So Colab makes some of the more time-consuming configuration processes also more streamlined, because it's almost like a graphical user interface that you put in your parameters and it does the programming behind the scenes for you. And so this avoids the need to configure your own computer with the tools for code development and implementation. So that brings us to the end of a very brief presentation. Really, it should be about an hour or so presentation that gives some worked examples of how you would use different tools and different code to produce a machine learning or deep learning project. But as a beginner step, to give you a bit of an idea of what some of the challenges and some of the tools that you might use, then it's actually a pretty good start. But more than happy to chat again at another time and give you some richer insights into the actual applications in terms of the code. So some Python coding associated with some of the neural networks, some worked examples of machine learning options, and I can even work you through the code associated with a Colab project, for example. But for now, we need to just sit there and think about how artificial intelligence, machine learning, and deep learning have an array of applications for nuclear medicine and molecular imaging and radiology more generally, and think about how those things might work. We need to think about that there's, generally speaking, a lot of narrow scope that's been in the literature. Think more broadly about how you could potentially problem solve in your department using machine learning or deep learning. It's important to identify problems that are fairly, immediate and have tangible benefits. So by solving those, that you're actually using machine learning or deep learning as a tool to solve a problem that has a tangible benefit, an immediate benefit to your department. In many cases, problems don't need artificial intelligence, machine learning, or deep learning. So don't overdo it. So don't overcook it. Don't try to jump into a big machine learning project or deep learning project when really you don't need those tools to solve the problem. Just find the simple solution. And so the most logical approach to developing any problem or project would be to start with machine learning. So think about the problem that you have. Think about how you could use machine learning to get richer and deeper insights into the problem. And then when you've got those richer and deeper insights, then start to think about how a deep learning approach might actually give you a more definitive outcome. So it's sort of a stepwise approach. Sometimes you don't need deep learning. And machine learning certainly allows you to make a more informed step into the deep learning arena. So that's all I have. Thanks for listening. If you have any questions or comments or discussion, you hit me up on social media, or my email address is gcurrie, G-C-U-R-R-I-E, at csu.charles.university.edu.au.
Thank you, Dr. Geoff Curry. And now we have our last speaker for the session, Dr. Arif Sheikh. He is the Diplomat, American Board of Nuclear Medicine and Diplomat, American Board of Internal Medicine. He is working as a Chief and Medical Director at Diagnostic Program, Kettering Institute, Ohio, USA. He has more than 20 years experience of working in nuclear medicine in various renowned nuclear medicine and radiology departments in USA. So over to him, Dr. Arif Sheikh.
Good afternoon, everybody. Thank you once again, for your kind invitation to the meeting. I am honored to be part of this meeting, especially that this is a multi-societal meeting. And I have been asked, I am in the US. I wish I could have joined you in person, but such is the case these days. And I will be presenting in clinical nuclear cardiology of beyond stress perfusion imaging. I believe some of the speakers are prior to me have talked about certain aspects of it, which of course I shall not cover. I shall try to cover other things that they may not have, and I apologize for not listening into the other studies because of the time difference. There's a, I would not have been able to sleep. Nevertheless, it's early in the morning here, and I'm happy to present, and I have no disclosures at this in this talk. Although as far as the US is concerned, I will talk about things that are not necessarily FDA approved or reimbursed over here by CMS, but it may be done at other places outside the US. So when we really look at cardiac parameters, we want to look at what's come in the past and what's in the future. And some of those things that are been done in the past are still relevant. For example, MUGA has been one, is a study that's somewhat oft forgotten. It has, in many cases, rightfully been replaced by echocardiograms. But nevertheless, it's important to realize, what did it do? We could do first pass evaluation for right ventricular function, look at left to right shunting. We could do equilibrium imaging for left ventricular evaluation. Look at diastolic heart failure. Now, remember, this is decades ago. This is about 40 years ago. We could just look at that. Whereas it was more a curiosity then. In the last 20 years, diastolic heart failure has become much more clinically important. So MUGA was able to do that several decades ago. And now there's also SPECT imaging in MUGA. However, if we were to look at right to left shunting, that's actually quite a different scan. We can talk about that briefly. And then the newer developments in fatty acid metabolism imaging and neurohumoral imaging are quite important. And I believe previous speakers would have talked about amyloidosis and viability, which I will not be touching upon. So MUGA is, despite everything, despite the advances in clinical echo, MUGA remains the gold standard for accurate assessment for left ventricular ejection fraction and function. And the reason for that is it has less inter-observer variability. It is more reproducible and repeatable than echocardiograms. That means you could do serial echoes, or have different readers look at the echoes and get more variability in echo reads than you would get with MUGA reads. Nevertheless, it is much more labor intensive than echo. It is more costly and has ionizing radiation, which echo does not use. And its uses for MUGA currently are, when you get equivocal echocardiographic results, if the cardiologist is astute enough, they should be referring patients for MUGAs. Sometimes you see changes in echo that could make a major clinical change in management, and to confirm those findings, you could do it with MUGA. In morbidly obese patients or women with large breasts, it can certainly be an issue trying to get through soft tissue, and MUGA would be better for that. But nowadays, if it is used, it's also used for following up cardiotoxic therapies. Sometimes you do it in shunt analysis in pediatric patients, but RVEF, and there are some newer approaches I'll be touching upon. So when we talk about planar RVEF assessment, it is a flow procedure. You basically inject, there's a bolus. And the good thing is that you can catch the RV in isolation, because when you have the LV blood pool come in, then there's overlap between the two, and that can obscure your ability to do an RV evaluation. The problem, of course, is that arrhythmias can invalidate the first pass study, because this is a gated study according to the ECG of the patient. That being said, there's no reason why a first pass RVEF cannot be done on just stress perfusion imaging. If you inject the patient underneath the camera at the time of injection, you could do a first pass analysis. And for that matter, if you're doing PET, you could do a dynamic PET analysis just as the patient's being injected. So you don't necessarily need to have a separate MUGA. You can do a lot of these procedures right into the camera, doing other procedures that you usually do. So looking at left to right shunt studies, this is almost completely replaced by echo. And, this is done with tagged RBC scans. And what we look at is recirculation time activity curves as the first pass is going through, because it's very difficult to visually assess what may be a shunt based on what the images show you. But again, like I said, you could similarly do a first pass analysis for SPECT perfusion studies or with PET. And in PET, of course, you're getting it in 3D, which is even better. So, these are methodologies that have been tried and proven, and you could be using them. This is shows you how a study would be done. For example, you can see there's a bolus that's going through, gets into the RV, and slowly gets into the outflow tract as we go along. You can see the lungs start getting blood pool activity. And here you'll notice that's where the LV is supposed to be. LV, of course, hasn't filled yet because it's still making its way through the lungs. But later in the study, you can see LV start showing up. Eventually, you start seeing it starts leaving the lungs, getting through the blood in the cardiac blood pool, getting into the aorta, and finally into the viscera. And finally, what happens is the blood spreads all over the body in the blood pool, and it starts equilibrating, and you can then get into the equilibrium phase. But nevertheless, if you look at draw regions of interest over the pulmonary flow and the systemic flow, you can come up with these curves. And based on these curves and times of appearance of these peaks, you can create a shunt ratio and therefore a shunt analysis of how much shunting is taking place and potentially to some extent where the shunt is. Some of you may recognize this because these are the type of curves that are generated when patients undergo catheterization and they do thermodilution studies to look at for shunting. And again, the concept is virtually identical. Of course, the difference is that MUGA is non-invasive, whereas catheterization is, of course, invasive. So as I mentioned, when we do LVEF studies these days, we're really looking at cardiotoxic toxicity and type therapies. And for example, doxorubicin was a classic drug. It was a toxic chemotherapy drug. And there have been algorithms that have been established where you would do a baseline study and then do it at various, after the patient's got various drug levels, you would repeat the MUGA study. Or to be cost effective, if the patient remains asymptomatic, no evidence of heart failure, you could do it at baseline and do it when you've gotten relatively higher doses of drug. And then also there's a clinical decision making algorithm with regards to, you know, how much of a change do you want to tolerate before you want to go and assess or maybe even stop the patient's drug, or if the patient's already got baseline heart failure, you know, when should you be doing the MAGA? So these algorithms have been there, but again, they're mostly replaced by echo, and doxorubicin, of course, is not being used as much as it has been in the past because of the presence of newer immunotherapies that have come up, bioimmunotherapies. But even with the bioimmunotherapies, there are certain algorithms because some of them are somewhat cardiotoxic. So by the same token, there are algorithms of potentially when to repeat the MAGA studies and, you know, if there are symptoms or not. But again, in most institutions, this is done by echo. And as I mentioned earlier, I think that is fine. You know, if there's stability or slow changes, that's okay. But whenever there's you know, the echo is showing something with changes management, it is my belief that the MUGA should be done at that time to confirm the findings. So some of the other parameters I mentioned, you could look at time activity curves of the equilibrium images to look at diastolic heart failure. I won't go into that. I want to talk more about dysynchrony and optimizing biventricular pacing evaluation. Why is that important in MUGAs? Because biventricular pacing has become more and more of an issue because there are an increasing number of patients with pacemakers. And a lot of times it's a result of a chronic heart failure. A lot of times that's due to ischemic heart disease. And as a result, patients have mechanical dysynchrony in the way their ventricles are contracting. And if you do not have good synchronized ventricles, you can have overall poor function of the patient, and overall prognosis has also been shown to be poor in those cases. So if you can correct those aberrant contractions with biventricular pacing leads, which therefore leads to improvement in the EF and potentially also patient outcomes. So for just as an example, here's a patient with you're looking at phase diagrams, which basically looks at the motion of the ventricles and say where are the areas of the peak and also what are the phases of the various parts of the ventricle. And you really want to have everything peaked kind of in a narrow area together. You don't want to see these spread out curves that we're seeing in the LV. So most of it are peaking at one area, but they are kind of spread out. Now, after appropriate placement of biventricular leads, you can see what happens is that the areas, the contraction the synchrony analysis shows that there is a better peaking and better phase motion of the ventricles, or both on the right side and the left side. And so this is, so even though this looks broader in the center, because you don't see this wide dispersion across the ventricle, this is actually an improvement in the patient's overall function. So this is a successful placement of leads and outcomes. This, on the other hand, shows where a case where this didn't work. For example, you do see a little bit of dispersion, but you see most of it come to, centered around a line. But here it disperses more after lead placement, both on the left side and right side and left side. And these, of course, now are worse. So the leads would have to be changed in location to get a better phase analysis. And of course, moving from planar MUGAs to SPECT MUGAs, there are certain advantages, of course, because this is an equilibrium scan and you don't have to do a first pass. You can do LVEF and RVEF analysis simultaneously. And you don't need to do first pass for RVEF. And if you're doing multi-planar studies of a MUGA, you might as well do you can do a SPECT because you get similar time of acquisition as the planar studies. You can avoid atrial and ventricular overlaps. But the problem is that the repeatability and reproducibility, which is what the key hallmark of MUGA is, has not been demonstrated with SPECT as yet. So, you're back to echo-like numbers, which is not desirable, because then you might as well do an echo. And it becomes a little bit difficult to combine first pass for shunting if you wanted to do that. Now, you could do it, but your tracer tagging of red blood cells is not as efficient if you want to do the first pass, because if you do it with efficient labeling, which is completely in vitro labeling, then you really can't, you can't get a good bolus, because there's a fair amount of volume that you have to give back to the patient. There's also variability in the software. There's lower temporal resolution. For example, planars, you can do 16 to 32 frames per R-to-R interval. Whereas in SPECT, because of the fewer counts you get, you're more restricted to 8 to 16 frames per interval. Nevertheless, does that make a big clinical difference? Maybe not, but you do get that poorer temporal resolution. And of course, one of the big problems is that RVF of SPECT has poor correlation with the first pass RVEF. And of course, we don't really have a gold standard, and nothing's been actually looked at properly as to which one is actually a better method. So you can have two discordant values and not really sure which ones you should be reporting. So this is a demonstration of a patient with a planar MUGA scan, as well as a SPECT MUGA, what that may look like. And again, you can see the ease of analysis of looking at the RVEF in this case. The planar MUGAs actually do look better than what you can probably see here, but they themselves, you can do a good LVEF analysis, but not so much an RVEF analysis because of the overlap of the various chambers of the heart. And again, as I emphasized and mentioned, all this can be done with flow studies using PET. So if you do initial flow study of PET, you could potentially you don't need to do MUGA if you have a PET in the department and access to, say, a rubidium generator or whatever PET agent have you. You could do a first pass RVEF and all these parameters with PET, which you don't necessarily need to do with MUGA. Now, right to left shunting is a little bit different, because here you want to look at shunting that goes in extrapulmonary vasculature. So you want to use macroaggregated albumin, which will get trapped in the pulmonary capillaries. And of course, this is what we use for VQ scanning. And therefore, you want to assess for extrapulmonary uptake, because if there is a right to left shunt, it's going to get past the capillaries and into the rest of the body. And when it does do so, you can quantify the shunting based on a whole body scan. And again, a lot of this has been replaced by echo, by bubble studies. But again, if you want to get a global assessment of the percent shunting, then certainly this is a useful study, particularly in pediatric patients. And this is an example of how a shunting study may look like, where you get the majority of uptake in the lungs. But again, if you do have right to left shunting, it'll bypass the lungs and go get trapped in the capillaries of the brain and kidneys and what have you. And you can take a big region of interest around the whole body to see what the counts are and compare it to the lung counts, and that can give you your shunting. Now you are in essence embolizing the brain, but again, the number of particles is very small, so you're likely not going to make a big difference. But again, keeping those particle numbers small when you're potentially looking at these studies is key to doing these procedures safely. And now we're going to move on to some more modern approaches in cardiovascular imaging, where fatty acid metabolism is a growing area of research with the